Welcome back, everyone. Today, I'll be your professor for a rapid-fire, high-yield clinical review masterclass. We're going to dive straight into those tricky clinical presentations that, let's be honest, easily trip students up on exams. We're going to focus exactly on how to differentiate them, so let's just get right into the explainer. All right, here's our syllabus for today. First, pediatric pearls and exclusions. Then, differentiating renal red flags. Third, recognizing life-threatening emergencies. Fourth, women's health high yields. And finally, neurology and ethics essentials. Okay, kicking things off with Section 1, pediatric pearls and exclusions. Let's start with a classic real-world scenario. You're examining a toddler and boom, you spot those totally distinct yellow honey-crusted lesions. Your clinical brain probably immediately screams impetigo, right? Or school sores. But then the parent looks at you and asks, so when can my child safely go back to daycare? I want you to lock in your answer right now. Well, the absolute golden rule you've got to remember here is the 24-hour rule. A child is excluded from school or daycare until exactly 24 hours after starting appropriate antibiotics. Usually that's going to be a topical like mupirocin or maybe oral flucloxacillin. But hey, there is a massive caveat here. Those sores absolutely must be completely covered with a waterproof dressing. If they aren't covered, no exceptions, that child stays home. All right, moving on. Let's contrast two super common pediatric scrotal masses. Now, with a hydrocele, the pathognomonic buzzword, the one that should always jump out at you, is positive transillumination. It actually surrounds the testis. You can manually get above the swelling. And the management, it's incredibly conservative. You just reassure and observe until they're about 1 to 2 years of age. Now, contrast that with an inguinal hernia. There's zero transillumination there. You might actually feel a cough impulse. And crucially, you literally cannot get above the swelling. Differentiating these two comes down entirely to trusting your physical exam skills. Moving right along to Section 2, differentiating renal red flags. Okay, these are two syndromes that get confused all the time. In nephrotic syndrome, I want you to think O for edema. You're going to see massive proteinuria, we're talking greater than 3.5 grams, along with severe generalized swelling. But importantly, they typically have a totally normal blood pressure. Contrast that with nephritic syndrome. Here, think I for inflammation. The absolute non-negotiable marker for this one is the presence of red blood cell casts in the urine. That, plus hypertension, and actually only mild proteinuria. Get those straight in your head and never mix them up again. All right, time for a massive red flag scenario. Picture this. Your patient is a 68-year-old man. He's got a 40-pack-year smoking history. Maybe he even worked as a painter back in the day. And he comes to you presenting with painless, visible blood in his urine. What is your absolute mandatory next step? I need you to think like an oncologist here. So, painless macroscopic hematuria in an older smoker, that is bladder cancer until proven otherwise. Here are your mandatory steps. Step 1, urinalysis just to confirm the blood. Step 2, get a CT urogram so we can view the upper tracts. And step 3, this is the really crucial part, mandatory cystoscopy. You absolutely have to look inside that bladder. And watch out for this high-yield distractor on exams. Even if your patient happens to be on warfarin and has a perfectly therapeutic INR, do not just blame the medication. You never assume, as cystoscopy is 100% non-negotiable. Let's keep the pace up. Section 3, recognizing life-threatening emergencies. When it comes to pneumothorax management, you've got to realize it's based entirely on rigid clinical stability pathways. For instance, if you have a primary spontaneous pneumothorax, it's pretty small, and the patient has totally normal vitals, you just observe them for about 4 to 6 hours. But let's change to presentation. What if there's tracheal deviation and hypotension? Well, that's a tension pneumothorax, and the only right answer there is immediate needle decompression. What about trauma? With a sucking open chest wound, you've got to apply a 3-sided occlusive dressing to essentially create a flutter valve. It's not guesswork, folks. It is pure algorithm. Okay, let's shift gears to a really high-tension obstetric emergency. Imagine you visualize an umbilical cord prolapse. The fetal monitor is showing variable decelerations, which obviously indicates cord compression. You quickly check the cervix, and it's 9 centimeters dilated. So what's your next move? Pay really, really close attention to that specific measurements. Right, so this is all about life-saving, temporizing measures. Step 1, you've got to get the mother into a knee-chest or Trendelenburg position. Step 2, manually elevate the presenting fetal part just to take the pressure right off that cord. And step 3, emergency cesarean section. Now, why is that? Because the cervix is only 9 centimeters. It's close, but it is not fully dilated. You see, if it were 10 centimeters, we'd go ahead and instruct the mother to push, or maybe attempt an instrumental delivery. But at 9 centimeters, an emergency C-section is literally the only correct answer.
All right, taking a breath here. Section 4, Women's Health High Yields.
So when we're talking about nipple discharge, it's really the pure color that dictates your clinical suspicion. In duct ectasia, that discharge is classically greenish or kind of multicolored, and it's thankfully associated with a very low malignancy risk. Physically, you might even see an inverted nipple with a distinct white line. But in an intraductal papilloma, the presentation is going to involve bloody or serosanguinous discharge, and that immediately raises the malignancy risk and completely changes your whole investigative approach.
Let's quickly review those strict Australian cervical screening rules. If HPV subtype 16 or 18 are detected, we know that carries the highest risk for dysplasia. So your immediate action is a direct referral for a colposcopy. But what if it's a non-16 or 18 HPV, maybe with a low-grade change like LSIL? In that case, you literally just repeat the test in 12 months. Now consider post-coital bleeding. Guys, this is a massive red flag. Even if their last screen was totally 100% normal, you completely bypass routine screening and jump straight to performing an immediate co-test and colposcopy.
Okay, we are on the home stretch. Section 5, Neurology and Ethics Essentials.
Let's do some rapid-fire pathognomonic buzzwords for Duchenne muscular dystrophy. First off, it's an X-linked recessive condition, meaning it primarily affects boys. The onset is typically right between 2 to 5 years old. Now, the classic physical exam finding you're looking for is the Gower sign. That's when the child uses their hands to physically climb up their own legs just to stand up. If you spot that and suspect DMD, your absolute best initial test is checking a creatine kinase level. It's going to be sky high. And crucially, especially for counseling the family, you need to know the greatest risk to their mortality. It's actually restrictive lung disease, which eventually leads to type 2 respiratory failure. All right, let's try a classic pediatric neurology vignette. Picture a 5-year-old boy. He suddenly just stares off blankly and starts bizarrely smacking his lips and sort of fidgeting with his clothes. The whole episode only lasts a minute, but then he's confused and drowsy for about 2 minutes afterwards, and he has absolutely zero memory of what just happened. So what are we thinking for the diagnosis here? Well, that lip-smacking behavior, that's exactly what we call an automatism. And when you pair that with the post-ictal confusion, this becomes a textbook classic presentation of temporal lobe epilepsy. Specifically, it's a complex partial seizure. And the high-yield pearl you need to take away here, the absolute first-line pharmacological treatment of choice is carbamazepine. Okay, switch gears and put on your medico-legal hat for a second. Consider this ethical scenario. You have an elderly terminal patient. They've got a super strict advance directive in place, refusing all surgery and resuscitation. Now they suffer a fall in their nursing home, sustain a head injury, and subsequently pass away. You were their doctor, and you knew they were already declining anyway. So can you just go ahead and sign the death certificate? The answer is absolutely not. It doesn't matter that they were terminal. Any expected death that ends up complicated by a recent fall or trauma legally requires an immediate referral to the coroner. You simply cannot sign that certificate. And while we're talking ethics, keep these other golden rules in mind. A competent patient's advance directive legally overrides any family disagreement, full stop. And when you're prioritizing comfort care right at the end of life, focus on the simple, humane things, like basic mouth care for a dry mouth, rather than resorting to invasive IV fluids. Just before I dismiss you, I've got one final, kind of provocative question for you to ponder. Let's say a young patient with a known history of recurrent oral and genital ulcers, which, as we know, points to Behçet's disease, suddenly presents with a really painful red eye, a severe uveitis. So we've got a multi-system autoimmune disease acting up here. What specific systemic treatment is required right now?
The answer? Oral prednisolone. See, because this is a systemic vasculitis that's flaring up, we don't just mess around with topical eye drops. No way. We need systemic oral steroids. And with that, we've reached the end of our rapid-fire review. Look, the main thing you should take away from this explainer is that clinical medicine is really just a giant puzzle. It's all about pattern recognition and completely understanding those strict rules of triage. But before you go, I want to leave you with this to chew on. If this exact same patient presented with sudden neurological deficits instead, how would that completely alter your immediate treatment hierarchy? Think about it. Keep reviewing, keep connecting those clinical systems, and thank you so much for joining me in this masterclass. See you next time.